Good evening, everyone. Welcome to our webinar tonight. My name is Dr. Shohreh Rezai. I'm one of the breast radiologists at Queensland X-ray, and I am going to speak to you tonight about contrast-enhanced mammography. Recently, earlier this year, we have obtained a new contrast-enhanced mammography unit at our imaging center at Mater Public Hospital. And since February this year, we've been using this technique. So I'm going to speak to you about this technology tonight. The outline of my talk tonight will be why should we use contrast-enhanced mammography. I'm going to talk about the technique, how we do it and obtain images, clinical indications, who would benefit from this test, and how do we report these images. In the end, I'll talk about limitations, and we will go through the questions at the end of my talk. So let's start. Why should we do contrast-enhanced mammography? I'm not going to bore you with all the statistics, but I'm sure we're all aware that breast cancer is the second most common cancer diagnosed in Australia after prostate cancer, and is the most common cancer in women. About 58 women are diagnosed every day in Australia with breast cancer, and 3 of them are very young, less than 40 years of age. Cancer Australia sort of estimated that about 21,000 women every year will be diagnosed with breast cancer in Australia, which is quite a large number of women. 1 in 7 women are diagnosed in their lifetime. So despite all these advancement in treatment and management of this disease, in terms of going into details of genetic testing and treatment options with immunotherapy and all the other new neoadjuvant chemotherapy regimen available, we all know that unfortunately the rate and incidence of this disease is increasing by about 24% in the past 10 years. So it is very important, therefore, to diagnose breast cancer at its early stage to be able to help women and save their lives as early as possible. If we can detect them, the better it will be. So contrast-enhanced mammography came along as a diagnostic tool to detect breast cancer. We know that mammography is the standard screening tool currently in Australia and everywhere in the world to detect breast cancer. And then the technology moved on, and tomosynthesis came along, when we will be able to go through slices and tissues through the breast parenchyma and assess the breast tissue better, and then contrast-enhanced mammography. It was actually approved by FDA years ago in 2011, and has been around in other parts of the world. In the United States and Europe, they have been using this technique for years. In Australia, it came around 2015, initially in Victoria, and then Perth in Western Australia. So Queensland is actually a bit behind in terms of adopting this new technology. So why we think it's better than 2D mammography in detecting breast cancer? Because it works in 2 different aspects of evaluation of the breast. One is the anatomical change, which is what the 2D mammography does. As a radiologist, our job is to go through the tissue and anatomical details and find the changes in the pattern of tissue to detect cancer. And that's one way. And then with contrast, when we inject the contrast, there will be tumor tissue absorbing that contrast material and showing us the tumor much easier. And the reason for that is we all know that the tumor cells produce abnormal blood vessels, what is called neoangiogenesis. So these blood vessels do not have normal endothelial layering. They leak because the endothelium is not intact. So when we inject the contrast, because of this leakage, the contrast will basically go into the surrounding tumor tissue much quicker and much denser than the rest of the normal parenchyma. It's exactly the same as the technique we use in MRI scan when we inject contrast dye and we see that specifics of the abnormal blood vessels in the tumor tissue. So because of that, we're using both physiological and perfusion abnormality of the tissue, as well as that anatomical change, which will improve our detection rate and improve our sensitivity. So multiple studies performed, and they basically all concluded that compared to digital mammography, the sensitivity is improved from 71% to almost 93%, which is quite significant. The same with specificity. We're detecting more and more tumor cells, which are the abnormal cells showing us contrast enhancement, and that's also improved from 51% to 68%. Especially, you can imagine if there is a dense breast and there's a lot of breast parenchymal tissue, contrast mammography can be very helpful to reduce the normal tissue and show us the abnormal cells and abnormal areas. There was a study performed on CEM for surveillance of breast after cancer in the first year post-op. Basically, patients received treatment, and the first year after the treatment, they evaluated around 1,200 patients, and out of these, 73 were recalled, 38 cancer diagnosis was made, and 41%, almost half of those, were only seen on CEM, contrast-enhanced mammography, and not on 2D mammography. So clearly, it shows that the sensitivity is much better than 2D mammogram. This is another table I got from an article that was published in 21, which went through multiple studies around the world. 4 of them here displayed from 2011 to 2014 and 2016, going through between sort of 140 to 200 women, and they came up with sensitivity and specificity, comparing it with 2D full-field digital mammography and CEM. And they all basically concluded that the sensitivity is definitely improved between 5 to 15%. Then the question comes that is it better than breast MRI? Should we use that instead of breast MRI? We know that MRI currently is the most sensitive test available for detection of breast cancer, and there has been multiple studies, meta-analysis comparing the two tools, and they all came up with similar sensitivity and specificity between the two tests. And CEM is getting very close in terms of sensitivity and specificity to MRI, although still MRI outperforms by sensitivity of up to 97% and a specificity of 74%. But CEM is not doing too bad, it's getting closer to MRI. We all are aware of limitations that MRI has, and that's mainly the availability of the test, which is very limited. We cannot access MRI for every patient, and also the cost that involves, and the issue with claustrophobia, because these patients need to lie down in magnet for 30 minutes, 45 minutes, and not all women can tolerate this due to claustrophobia. So there are limitations with MRI, and in these situations, CEM can be of help. I sort of tried to create a table comparing the two tests, because we know that these are the two best available tests currently to assess breast cancer, and just going through that to show you the differences between the two techniques. Talked about specificity and sensitivity already, so we know MRI is still a little better than CEM. We use IV gadolinium for MRI, and for contrast-enhanced mammography, we use iodine-based contrast agent. There is obviously radiation exposure with contrast mammography. And in terms of contraindication, if patients have pacemaker or metal in their body, or they're claustrophobic, or in very obese patients, we kind of cannot perform MRI. Contraindications for contrast-enhanced mammography is only limited to anaphylactic reaction if patients have history of that, or a severe renal impairment. And by that, I mean the eGFR of less than 30. If it's that severe, then we cannot basically give contrast. In terms of accessibility, MRI is obviously not widely available compared to CEM, which can be easily accessed if it is around. Cost of MRI is higher than CEM. In terms of anatomical coverage, we get more details with MRI because we can include chest wall, bilateral axilla, and it's definitely more coverage of tissue with MRI. Patients who have breast implants, MRI is a better test for them because we get more details in women with breast implant. We can still do contrast mammography, but MRI is a better test. In terms of post-processing data and assessment, with MRI, we get 3D high-resolution images through the breast parenchyma, and also with the contrast injection, we do the dynamic assessment. We can do arterial phase and then the washout and the delayed phase, so we can assess any lesion that is enhancing in a better detailed way to characterize. Whereas with CEM, it's only a 2D image and single phase contrast that we look at. So these are the differences between the two techniques. There is movement artifact risk with MRI because the breast is not compressed. When we do MRI, patients lie down prone on the table for about 30 minutes, 45 minutes, as I mentioned, and there's always risk of movement, which can degrade images. Whereas in CEM, breast will be compressed and much quicker, in a much quicker way, the images will be obtained. So movement artifact is not that much of an issue. We can now perform contrast-enhanced guided biopsy, as well as MRI guided biopsy that has been around. So both techniques are now available. I will talk about it a bit further when we move on to my talk. Okay, in terms of technique, how is this done? Patient comes in. Our technician will put a cannula in. It's kind of similar to when they receive a CT scan. They'll get a CT scan. They put a cannula in. They inject the contrast agent, which is 1.5 ml per kg. And after 2 minutes, they will position the lady for a mammogram. Similar to our routine mammography, images will be done in 2 views for each breast, which is craniocaudal and medial lateral oblique projections. So say the technician will position the lady in craniocaudal position of right breast, but instead of obtaining only 1 image, when we do routine 2D mammography, this time the machine will take 2 images in the same position. One is with low energy or low kV, which will be exactly similar to the 2D mammography image, and one image will be high kV or high energy when there will be a lot of X-ray penetrating, and then that would basically get rid of the tissue, and just the iodine stained area will stand out, basically, just to sort of simplify it in a simplified way. And then we can see it better. So 2 images will be obtained from each projection and then move on to MLO and then the other breast. They have about 8 to 10 minutes to finish the study. That's the amount of time that we allow to have a contrast in the breast tissue to be able to get images. And usually this is sufficient for our mammographers to perform the images. If there is any obvious enhancement in a breast, they will perform a true lateral projection as well that will guide us for future biopsies if needed, and we can plan it better. So when the images are obtained, then there is a post-processing performed, and the images are sort of labeled as low energy, and the recombined image is the contrast image that we will see. And then they will send that to our PACS so the radiologist can assess that. So the radiologist will review both sets of imaging, both the low energy as well as the recombined imaging. There is no need to check the menstrual cycle phase for contrast mammography. Studies shown that that makes no difference, so they can have it done at any time during their menstrual cycle. So this will be the images that will get sent to our PACS for reporting. On the left-hand side, you can see it's kind of like a normal mammogram, MLO and CC projections. MLO is on the top and the CC craniocaudal on the bottom. And then on the right-hand side of the image, we can see the recombined image where there is a high kV showing us the enhancing mass in the superior right breast, which you can imagine. You can see that how much easier we can detect the abnormality compared to the 2D images when we kind of get rid of all the background tissue and just show the abnormality. Our booking staff are trained to schedule patients prior to their arrival. They'll check history of renal impairment. They'll check if they had allergic reaction to contrast, and if they need to get any blood tests done before the scan to make sure that the renal function is okay. Our mammographers are trained to put a cannula in, and in case of contrast reaction, they are able to help patients until basically the team arrives. The contrast reaction rate is similar to contrast reaction for any other tests that we do, CT scans that we do. It's really not high. It's less than 1% and not very commonly seen. There will be obviously extra cost. At Queensland X-ray, we only charge a small amount for cannulation and the IV contrast that we inject to the patients, but that will be extra to their routine payments for the mammogram and ultrasound. In terms of radiation dose, is there increased dose? Yes, there's multiple studies, and Gennaro was one of them, which published about 30% increase in absorbed dose compared to the standard 2D mammography. But the increased dose is very similar to tomosynthesis imaging, and I think like many places these days perform tomosynthesis imaging anyway, so it will be very similar dose to that. And currently, it shouldn't be limiting us not performing contrast-enhanced mammography if there is a benefit from that test. So we should not limit ourselves. And mammography itself is a low radiation test by itself. So adding 30% is not a huge amount of radiation dose, but we will consider that. And because of that, it is not currently recommended for routine population screening as yet, not in Australia and not anywhere else in the world as yet. The newer technology will come on, and they work on lowering radiation dose. Now moving on into clinical indications and who should really get the test. On the right-hand side is a table that I got from the American BI-RADS lexicon, which basically gives us the indication for contrast mammography, which are approved. And here in Australia, we use it for assessment of abnormalities that are detected during screening mammography, and the lady comes in for assessment. Contrast mammography will be ideal to look and further investigate the area. For women who have a palpable lump, and 2D mammography and ultrasound do not help, or we cannot really finalize that decision, or they're not conclusive, then a contrast-enhanced mammography is very helpful. Definitely, we know that the sensitivity of CEM is higher, so it's better if they are symptomatic and they have a palpable lump to assess them with CEM. If they've got proven malignancy for the assessment of extent of disease, it's been shown that it is quite helpful, and we can do it quicker and much quicker than MRI. On a day, we can assess it, we can show the extent of disease if it's much more than what we sort of anticipated on the 2D imaging. Also, we get referrals from our oncologist for monitoring response to neoadjuvant chemotherapy. Again, similar to MRI that we use in some cases, we could use contrast-enhanced mammography, and we assess them during their treatment, before the treatment and during their treatment, and basically after the finished treatment, if there is any residual enhancement in the tumor site, that basically means that there is no complete response to treatment. And in the end, the group that will benefit from contrast mammography will be the women with intermediate risk, women who are high risk, which are women who are at risk of lifetime risk of greater than 20%. In Australia, they are eligible for annual screening MRI, and they should still do that, and they should get MRI. But for women who are in intermediate risk, less than that, but not in sort of low risk group, they will definitely benefit from CEM. And also women who have dense breast, that I think there's no brainer, contrast-enhanced mammography will help in those group. This study was performed this year recently in Australia. It's an Australian published study, which was published in July, and they basically looked at contrast-enhanced mammography in surveillance of women who had personal history of breast cancer, and they compared that to 2D mammogram, and they concluded that this has definite improvement in detection of clinically significant malignant lesions when we use contrast-enhanced mammography. So they're really advocating using this in post-surgical follow-up women, which is quite a fantastic study that came out. And then there's another study was performed in 2022, was published, and that kind of reviewed 15 studies from different sites, reviewed about 1,400 patients, and they basically who had intermediate risk for breast cancer, and they concluded that the sensitivity of CEM was really good and close to MRI. So they sort of suggest that for intermediate risk group women, CEM would be a really fantastic screening tool. Okay, and how do we report that? We use BI-RADS lexicon in our reporting. I'm sure you have seen, many of you have seen reports that talks about BI-RADS, and in the conclusion of the report, we put the category, which is category from 0 to category 6. Category 0 basically means that radiologists think that the study not conclusive for them. They need more information. They either need previous imaging to compare to, they need extra images, whether it be more compression studies or more ultrasound images, or even MRI scans. So that means category 0, that means this lady needs further workup. Category 1 means nothing is seen, everything's okay. Category 2 is benign. BI-RADS category 3 means there is an abnormality in the breast, but the chances of this being malignant is less than 2%. In Australia, we tend to biopsy majority of these category 3 patients because we want to reduce the anxiety and sort of clarify things for patients. So we tend to biopsy majority of our BI-RADS 3 patients categories, but sometimes we may decide to perform a short-term 6 months follow-up. Category 4 and 5 are suspicious lesions when we think that they're highly likely to be malignant, and BI-RADS category 6 means that they are biopsy-proven malignant lesions in the breast. So we use that BI-RADS lexicon, and in our reporting, when the radiologist reports CEM, it will assess the 2D images, or if the tomosynthesis imaging has been done as well, they will review all of those, talk about all the abnormalities, the same as whatever we normally do. And then in the end, you might you might see another paragraph added, which talks about the background enhancement of the breast, and then the abnormalities that is enhancing, whether it's an enhancing mass, or whether it's a non-mass enhancement, which is a region of enhancement. It's not mass per se, but it's just a region of enhancement, or whether it's an enhancing asymmetry, which means that enhancement is only seen in one view, one projection, not in both projections of that breast. This is an example of a background enhancement of the breast that I'm showing you. The image on the left-hand side is minimal enhancement, and then we talk about mild enhancement on the second image. The third image shows a moderate amount of background enhancement, and the last image on the right shows marked enhancement, when you see a lot of tissue enhancing. And you can imagine how difficult that will be for a radiologist to detect a cancer if there is that much background enhancement in the breast. In my experience, I sort of the background enhancement that I see in the CEM is less than what we're facing when we're reporting MRIs, breast MRIs. Often the background enhancement is more intense on MRI, which makes it a bit more challenging for us. But often usually I see either minimal or mild background enhancement in majority of CEM cases. Okay, so that's basically it. Let me show you some examples that really proved to at least myself that CEM is a helpful tool. This is one of our very first ladies that we scanned at Mater Hospital, 55-year-old lady. She was sent to us from breast surgeons. She had a breast screen detected left breast cancer, and they found an abnormality on the mammogram on the left side, and they said, can you assess her before we give her treatment? So this is her mammogram that was performed at breast screen. We can see that she is heterogeneously dense. The malignant mass was this irregular mass in the superior left breast, we can see. But then she had this further density at the back, and they said, can we assess that? So we did an ultrasound. On ultrasound, this is the malignant biopsy-proven cancer at 10 o'clock, 4 centimeter from nipple in the left breast, which measures about 3 centimeter in size. So we found that, but we also found another smaller area at 8 o'clock, 5 centimeter, which measured about 12 by 11 millimeter, which we thought correlates to the other density. She also had another area at 8 o'clock, 5 centimeter, a bit closer to the skin. And she had an abnormal looking lymph node in the axilla, which was quite hypoechoic and large. We biopsied all the other 2 areas that we saw, and we sampled the axillary lymph nodes. They all came back as malignant IDC in the breast at 8 o'clock, and the lymph node was also metastatic. And we said, okay, we have contrast mammography. Let's do CEM and see what we find. So this is her CEM. We can see the enhancing mass. This is the biopsy-proven cancer that was initially biopsied. That was the second area that also shows enhancement. But also we found there is extensive region of non-mass enhancement in a segmental pattern involving lower inner quadrant of the breast, extending from the nipple far posteriorly. So we said the extent of disease is really much more than what we saw on ultrasound and mammogram. She's got really extensive disease in that quadrant of the breast. Not only that, on the contralateral breast, the right side, she had a portocat inserted because she wanted to start neoadjuvant chemotherapy. We found this small irregular enhancing mass in the superior outer breast, and this asymmetry, enhancing asymmetry further up. So we said this also looks suspicious. This needs further workup. We did ultrasound, and our sonographer found this small irregular area in the right breast at 11 o'clock, 10 centimeter from nipple, and we thought, okay, maybe that's, you know, the small mass. I biopsied the mass and came back as benign fibrocystic change. And we thought that does not correlate with the enhancement that we saw on the CEM. We brought her back. We did CEM guided biopsy. Here on the right, you can see my needle through that area of enhancement in the breast. I left a marker in there. That was the marker from the ultrasound guided biopsy. This is my marker from CEM guided biopsy. And we can see that that's the area of enhancement which correlates with the marker that I put in from CEM. And the result came back as invasive ductal carcinoma, non-specific type, ERPL positive. So we basically went from detecting a small cancer, a 3 centimeter cancer in the left breast, to this lady having bilateral disease quite extensively, and she ended up having bilateral mastectomy, so changed her management plan completely. The second example is a 40-year-old LB. She presented with a palpable lump in her left breast. This is her 2D digital mammography. She is heterogeneously dense. Yes, there is more dense tissue in the left compared to the right, but really I couldn't detect any spiculated mass. I couldn't see microcalcifications, distortion, not much else was seen. There was no skin thickening. She had an ultrasound of the area of lump, and we found at 3 o'clock, 3 centimeter from nipple, this small irregular hypoechoic mass, measured about 1 centimeter in size. I biopsied that, and that came back as invasive carcinoma, non-specific type, ERPL positive, HER2 negative. We said, okay, we have contrast mammography. Let's do CEM. And here it is, her CEM. You can see there is no enhancement in the right breast, which is good. But in the left, we can see that enhancing mass, which probably is that area correlating with that ultrasound mass and a palpable area. But look at this extensive non-mass segmental enhancement involving the whole upper outer quadrant of the breast. We said, okay, this is abnormal and nothing seen on 2D or mammogram or ultrasound. I performed, again, contrast enhanced guided biopsy. I did 2 biopsies from 2 quadrants, like one at superior and one on lateral aspect of the breast. Left a marker in, both came back as DCIS and IDC. So she, again, having a 1 centimeter lesion detected on ultrasound, now having extensive disease, and she also ended up having a mastectomy. Another third example, just to show you the use of CEM, a 59-year-old CN, she had past history of right breast cancer in 2019. She had treatment. It was grade 1 invasive carcinoma plus DCIS. She received the surgery and radiotherapy, and she was on letrozole. So she came for her mammogram, Sorry, I'll just take that back. We can see that she's quite dense. Sorry, I don't know why it's projecting, but it's a BI-RADS D, quite dense breast. Yes, we could see the distortion in the upper outer left breast from surgery, but who knows what's going on underneath this dense breast. But we can see that on contrast mammography, how great is that? Like there's negative, like black, nothing enhancing. So that kind of tells me there's nothing in the scar that is enhancing, nothing enhancing anywhere else. This lady really does not even need to have ultrasound. We only do an ultrasound of the axilla looking at the lymph nodes, and that's it. And the workflow is much, much easier than for post-surgical follow-up cases if we can get these images. And finally, talk about limitations of the study, background parenchymal enhancement, as I talk about. If it's quite marked, that could limit us in assessment of the breast. It's usually higher in premenopausal patients and those who have dense breast to begin with. And as I mentioned previously, no need to check menstrual cycle. There is a slight increased radiation dose that we talk about, which should not limit us really in making a decision of whether this lady needs to have CEM. If they need it, they should get it. They need to have IV cannula and contrast, and the limitations with renal impairment and allergic reaction we talked about, and obviously the extra cost that we talked about. In the end, I'm going to talk about contrast-enhanced biopsy. I showed you examples of that. It is useful in cases where we cannot find abnormality on our 2D mammography or tomosynthesis or ultrasound, and we can only see the enhancement. Definitely contrast-enhanced mammography can be helpful. Also, if we see an abnormality on MRI, performing a biopsy on the MR is much more complex. It takes more time. Booking is more difficult and it's much more expensive. If we can find the same area of enhancement on CEM, it's much quicker, much easier, and cheaper to perform it that way. So I think that should also be a way to consider performing biopsies. So in conclusion, contrast-enhanced mammography is a great diagnostic as well as screening tool with improved sensitivity and specificity compared to our 2D and 3D mammography, because it assesses both anatomical changes in the breast as well as the perfusion change in the tumor tissue that will help us detecting the tumors easier. The indications include in a screening for intermediate risk group people, women with very dense breast, as well as diagnostic tools for complex cases when they are unresolved on mammogram and ultrasound, also for post-surgical follow-up imaging cases, patients, as well as to assess the extent of disease and response to neoadjuvant chemotherapy. It can also guide us perform CEM biopsy if need be. So that is my talk about contrast-enhanced mammography. Just the last slide, I'm going to talk about the referrals and the request for breast imaging, basically, which we receive so many of them every day. If a woman is older than 40 and is symptomatic, ideally, we want to have the request including mammogram, ultrasound, plus minus biopsy. And that way, we basically make sure that everything is done for that lady on that same visit. And everything, you know, the way that it's done, I'll just explain it quickly. The mammographer will check with the patient if they had any mammogram in the past 12 months. If they did have it done, we will request those images to get sent to us. If they're done at breast screen, it's much easier to transfer them to our system. If they're done elsewhere, it's a bit more difficult, but still we will chase them and try to get those images. If the woman hasn't had any imaging done in the past 12 months, then we will obtain a mammogram. So we will check with the ladies before we actually do the test. So we don't double up mammogram in 1 year for a lady or, you know, things like that. And then the radiographer will come and check the mammogram with the radiologist in the room. The radiologist will review all the images, ask for extra image if need be, or extra views. And then the mammographer will do those, check them again with a radiologist. The radiologist will make sort of marks area of interest. And then the sonographer will image the patient and bring back all those images and check with the radiologist again. The radiologist might go in and check the lady themselves. If the biopsy is needed, they'll get it done on the same day. So you can see it's quite a lengthy process for the whole day that we sort of spend a long time with these patients, try to sort them out on the same visit. If we have a request only saying mammogram and no ultrasound, we cannot perform ultrasound. And then our staff need to contact your practice. And oftentimes you may not work on a day, or you're busy seeing patients. We all are busy, you guys also busy seeing your patients. You cannot give us the request in a timely manner. And this would just affect the patients because they have to go back and revisit us. Just creates more anxiety, cost, and travel time. So to be able to be very efficient, we actually created a form at Queensland X-ray, which includes mammogram, ultrasound, plus minus biopsy, and you just tick the box and just leave it to the radiologist, and the radiologist will then perform necessary tests and try to fit everything on the same day and finish the studies. It would be ideal for the women, especially those who are post-septical, to perform the imaging at the same practice. It's just because it's much easier for the radiologist to compare with the previous imaging, which really, really help us to solve problems. It's really painful if we have a request for a biopsy and the woman has done mammogram in one imaging center and ultrasound in another center, and none of those images are available to us, and the lady presents with a request for a biopsy. You can imagine how difficult that would be for us. So if you please just make sure that you talk to your patients and sort of make sure they present to the same place, or I know it cannot be possible at all the times, but if it is, that would definitely help us. Thank you so much for listening. I hope that was helpful. And October is Breast Cancer Awareness Month. Please share that. Thank you so much. We're now going through some questions that Carly very kindly sending those questions to me. Okay, from Dr. Susan, who's asking, should we use CEM for monitoring of breast cancer patients yearly who have dense breast? Yes, absolutely, we should. Detection limit in terms of size of the lesions, 5 millimeters. Basically, yes, if it's a very small lesion, we may not be able to see it on contrast enhanced mammography. As I mentioned, the resolution of images are not similar to MRI. Lesions that are small, say 5 millimeter or smaller, we may not be able to see, but definitely we can see larger masses and area of non-mass enhancement. If they have allergy to iodine, can they have gadolinium? We could. I myself have not tried gadolinium for contrast enhanced mammography, but if patients do have allergic reaction for, say, CT scans, we try them. I would think that we should be able to do it, but I myself haven't basically done that yet. There is another question from Dr. Chen. For women with intermediate risk and dense breast, can CEM be used every second year for screening? Yes, basically, as I said, if the woman presents themselves to Breast Screen Australia, we do not offer contrast enhanced mammography. We don't have contrast enhanced mammography in those centers, so they can't go there. But definitely at other centers, if their images are, if the CEM is available, they can do it every second year. Intermediate risk group women, I do recommend that they should get yearly screening. There is another question. What about multiple fibroadenomas in the breast? Will this be an option? Fibroadenomas also show enhancement, is similar to when we do MRI. They do show enhancement. In those cases, we will assess, obviously, any enhancing mass by ultrasound. It's helpful if they come for follow-up, so we have them and we sort of compare with the previous image. If there is any new enhancing mass, then we can just do a targeted ultrasound to assess that new mass. But if the rest of the fibroadenomas remain unchanged, we can easily say those fibroadenomas are stable, so move on. So we don't need to re-ultrasound them basically every year when they come for their screening, but they do show enhancement. Okay, so if we ask that all our staff, if anyone else has any questions, please email us. I'm more than happy to answer those questions. But other than that, thank you so much for listening and have a good night.